Our next speaker will be Dr. Mary Hébert. Dr. Hébert's research on pharmacokinetics in pregnancy has drawn international attention to the urgent need for new protocols for prescribing to pregnant women. In particular, her groundbreaking study on amoxicillin as a treatment for anthrax illustrated the dangers of excluding pregnant women from clinical trials. Dr. Hébert is a professor of pharmacy and an adjunct professor of obstetrics and gynecology at the University of Washington. She is also the director of the university's Obstetric Fetal Pharmacology Research Unit, a core member of the Center for Echogenetics and Environmental Health, and a member of the Institute of Translational Health Sciences. Her clinical research is focused on pharmacokinetic and pharmacodynamics and a mechanistic basis for clinical pharmacologic changes and medications of therapeutic value during pregnancy. Please join me in welcoming Dr. Hébert.
Thank you. It's my pleasure to be here today and talk to you about some of the pharmacokinetic changes that occur during pregnancy. I think that this is just going to be a glimpse at the changes that there are. The more that we look, the more differences we're identifying. I don't have any conflicts of interest. And pretty much everything I'm going to talk about should be considered off-label use, either because the indication in pregnancy has not been studied or because the dose changes that we're seeing for pregnancy is not included in the labeling. By the end of the talk, I hope that you will have an understanding of the effects of pregnancy on renal filtration and drug transport, drug metabolism, changes in protein binding, and then the clinical implications of some of these changes. Starting off with real basics, these are stereotypic oral concentration time profiles. Taking a look at the green line, as the drug is absorbed, obviously the concentrations rise. At some point they peak, and as the drug finishes distribution and is eliminated, the concentrations fall off. There are many disease states and drug interactions, as well as conditions such as pregnancy that can alter these concentration time profiles, such that they look more like the red line, where you have concentrations exceeding maximum tolerated concentrations, or the blue line, where the concentrations never reach the minimum effective concentration. Clinically, what we typically do when the concentration time profiles change as a result of drug interactions or a disease state is to modify the dosage regimen so the concentrations look more like the population in which the drug has been approved. I'm going to start with the kidney. Drugs, I'll talk about filtration and transport. About a third of the medications that we're using clinically are eliminated by the kidneys. We know that renal filtration, as measured by creatinine clearance, increases starting in the first trimester, peaks somewhere mid-second trimester, and falls off in the last few weeks in some individuals. Like Dawn, we are very interested in drugs used in diabetes management, and there is a parallel rise in creatinine clearance in women with BMIs less than 30 and women with BMIs exceeding 30. The changes that we see in creatinine clearance do correlate with the renal clearance of drugs. This is our data looking at Atenolol renal clearance versus creatinine clearance, and you can see there's quite a good correlation between the two, from creatinine clearances as low as about 50 mils a minute to as high as almost 400 mils a minute that you'll see in the obese pregnant woman. It's not just Atenolol where we see changes in the pharmacokinetics. This is our data looking at amoxicillin in the second and third trimesters of pregnancy compared to 3 months postpartum. The closed circle being second trimester, triangles being third trimester, and the squares being postpartum. You can see that the concentrations are substantially lower in pregnancy as compared to the postpartum state. So why on earth would we study amoxicillin in pregnancy? the time of us doing this study, there was the big anthrax scare, with anthrax being sent via the U.S. Postal Service to the Senate buildings and to one of the news stations in the United States. And at that time, there were recommendations for how pregnant women should be treated in the case of an anthrax exposure. And the recommendations were actually published both in JAMA and another OB journal. And both of them recommending 500 milligrams of amoxicillin 3 times a day for anthrax prophylaxis. And this is a 60-day regimen that you have to treat these women. When I did the analysis on the pharmacokinetics, I immediately was concerned because the half-life in pregnancy for amoxicillin was just over 1 hour. And if you're dosing the drug every 8 hours, clearly there was not going to be any drug around by the end of the dosing interval. Anthrax is an interesting organism, and there's no post-antibiotic effect. So in order to have therapeutic systemic concentrations by the end of the dosing interval, we need to look at alternate regimens. We looked at multiple types of regimens, and the only way to get the amoxicillin concentration above the MIC for a sensitive isolate, which is 0.12 mics per mil, is to dose the drug every 4 hours. Now, I'm not sure about the people in this room, but how many of you think you could actually take a drug every 4 hours for 60 days? The chances are pretty slim. And of course, this concerned me as well as the FDA when I presented the data to them. And there has been a great deal of discussion about the guidelines and some move towards changing them for pregnant women. So it's not just renal filtration that's changing. We also need to talk about some of the other effects that occur for the elimination of drugs through the kidney. There is passive and active movement of drugs in the kidney. What I'm going to talk about now is net renal secretion, so the active transport of drugs into the urine. We've done 3 studies that have looked at net renal secretion of drugs, and we use these as examples of how transporters may or may not be changing during pregnancy. The first study we did was looking at Digoxin Pharmacokinetics. We gave a low dose of digoxin in the 3rd trimester of pregnancy compared to the same women 6 to 10 weeks postpartum, and looked at renal elimination and that net renal secretion. And it was doubled in pregnancy. So digoxin's the gold standard probe for peak glycoprotein. And as I said, the net renal secretion was doubled in pregnancy. Amoxicillin is a substrate for organic anion transporter that actively secretes amoxicillin into the urine. It's also reabsorbed by HPEP T1 and T2. If you look at the net renal secretion in the 2nd and 3rd trimesters of pregnancy compared to those same women 3 months postpartum, there's about 100 mils a minute increase in the net renal secretion for amoxicillin, both in 2nd and 3rd trimesters. And the 3rd drug we've looked at, the net secretion, is metformin, which is a substrate for organic cation transporter 2 in the kidney. And the net renal secretion in the 2nd and 3rd trimesters of pregnancy, but not the 1st. So 2nd and 3rd trimesters of pregnancy is increased by over 100 mils a minute. So this is a little bit confounded because metformin is an intermediate extraction ratio drug, and we do know that there's changes in renal blood flow during pregnancy, and so it would be both dependent on blood flow and both as well as active transport. But how this translates is to, these are oral concentration time profiles at steady state for women, pregnant women in the 1st, 2nd, and 3rd trimesters of pregnancy compared to 3 months postpartum. And all these women were receiving 500 milligrams twice daily of metformin, the concentrations being lower in pregnancy compared to the non-pregnant state. The numbers in this particular graph are fairly small, and we've got a much larger scale study ongoing. We'll shift our attention a little bit from the renal elimination drugs to metabolism, which primarily takes place in the liver and intestines, although we all know that drug metabolism can occur in other places in the body, including the kidney and lung and so on, depending on the drug. I'll talk a little bit about changes in some of the enzymes that are involved in phase 1 metabolism, and then one of the enzymes involved in phase 2 metabolism. These pie charts are broken down by the percent of drugs eliminated by each of these enzymes. For phase 1 metabolism, you can see that CYP3A is involved in the metabolism of more drugs than any other P450s. 2D6 is fairly high, as well as 2C9. And then smaller pieces of the pie for 1A2 and 2C19. On the phase 2, the largest piece of the pie is made up by the UGTs. Starting with cytochrome P450 1A2, this is data from Tim Tracy and others looking at the activity of 1A2 by using a probe, caffeine, as a marker of enzyme activity. And over the course of gestation, there's a 33 to 65% decrease in activity in 1A2 activity, in 1A2. So decreased activity, we're going to have higher concentrations clinically during pregnancy as compared to the non-pregnant state, and the postpartum control was 6 to 8 weeks postpartum. Another enzyme that appears to have decreased activity in pregnancy is cytochrome P450 2C19. This is data with proguanil, and the bars are representing the ratio of proguanil to cycloguanil. So the higher the bar, the lower the activity. In the poor metabolizers, there wasn't a significant difference, but in the extensive metabolizers, there's an increased ratio of proguanil to cycloguanil, suggesting a decreased activity during pregnancy. And this is 3rd trimester versus 2 months postpartum. In contrast to CYP1A2 and 2C19, cytochrome P450 2D6 activity appears to be increased across gestation. Again, this is Tim Tracy's data looking at dextromethorphan as the probe. It's not ideal because it has some metabolism by 3A as well, but they showed an increase between 25 up to 50% later in pregnancy in 2D6 activity. So consistent with the dextromethorphan data is this data with metoprolol, the gold standard probe for 2D6 activity. And on the top part of the table is oral administration, the bottom part being intravenous administration. With oral administration, there's a very much lower total drug exposure in pregnancy as compared to the non-pregnant state. And we have similar data, although not yet published, showing a 2 to 6-fold decrease in total drug exposure to metoprolol during pregnancy. It's somewhat surprising given that 2D6 was supposed to be the non-inducible enzyme, but in pregnancy it does appear to be markedly increased in activity. Metoprolol being a beta blocker, I think it's important that we all remember we're not seeing changes just in the pharmacokinetics, we're also seeing changes in hemodynamics. This is the heart rate, normal heart rate across gestation, and you see a gradual rise until almost the end of pregnancy. It's stable for a short period of time and then returns to baseline postpartum. So if you're treating something where you're trying to beta block somebody and drop their heart rate, it's a moving target as to what you're trying to achieve. Similar to what we see with cytochrome P452D6, we also see an increased activity with cytochrome P453A. This is our data with midazolam. We gave a very small tracer dose of midazolam in the 3rd trimester of pregnancy and compared it to women 6 to 10 weeks postpartum. And the blue line representing the women that are pregnant and their postpartum control day represented by the pink line. You can see the concentrations are markedly lower in pregnancy as compared to the non-pregnant state. So the pharmacokinetic parameters are consistent with this. The total drug exposure is about half in pregnancy as compared to the non-pregnant state. Maximum concentrations are also lower. Apparent oral clearance is more than doubled, and we looked at the 1-hydroxymidazolam formation clearance, which is also more than doubled in pregnancy compared to the non-pregnant state. Now, for those of you who have studied midazolam, you, I'm sure, are familiar that it's a highly protein-bound drug. We looked at protein binding in these women and found small changes in the percent unbound during pregnancy, and certainly not enough to explain the changes in apparent oral clearance, that even the unbound apparent oral clearance is still almost doubled in pregnancy. Midazolam is a very good substrate for cytochrome P453A, so it looks as though 3A activity is also markedly increased. Now, indinavir is a drug used to treat HIV, and this data, first of all, indinavir is a substrate for cytochrome P453A as well as P-glycoprotein. If we look at total drug exposure as measured by area under the concentration time curve, you can see here that the average concentration is 1/3 in pregnancy of the non-pregnant state. The postpartum data is consistent with pharmacokinetics in other non-pregnant populations, and so it truly is pregnancy that is so much lower. Indinavir, of course, is a drug that you would not want to have subtherapeutic concentrations. The HIV organism is very quick to mutate and become resistant, and because of this data, it is recommended to not use indinavir by itself in pregnancy. You either need to use a booster or an alternate drug to get the concentrations high enough. So 2D6 activities increased, CYP3A activities increased, and 2C9 activity appears to be increased as well. What you're looking at here is the free phenytoin clearance. Phenytoin is a substrate for 2C9, and in all 3 trimesters of pregnancy, as compared to the pre-pregnancy state, there is an increase in free phenytoin clearance. Most of the studies that are done in pregnancy look at them while they're pregnant and then study them again postpartum. This is one of the few studies that looked at them prior to getting pregnant. Phenytoin is a drug that is, we do therapeutic monitoring all the time, and so it's important, well, it's easier to catch people prior to getting pregnant with a drug like phenytoin. This is our data looking at the pharmacokinetics of glyburide in women in the 3rd trimester of pregnancy with gestational diabetes compared to non-pregnant women receiving glyburide for type 2 diabetes. The pregnant women are represented by the solid line. The dotted line represents the women that are not pregnant with type 2 diabetes mellitus. And you can see concentrations in pregnancy are markedly lower. And if you take a look at the y-axis, you're looking at a log scale, so these differences are quite substantial. We took the data from this study and did modeling and simulations, trying to figure out approximately what the dosage range would be if you tried to achieve the same concentrations as in the non-pregnant population. So the blue lines border the 99% confidence interval for the non-pregnant women with type 2 diabetes, a simulated population, and then the red lines are the simulated population of women with gestational diabetes. And in order to make the concentrations comparable, as you can see, that they are fairly comparable. A dose of 1.25 up to 23.75 milligrams twice daily would be needed to achieve the same concentrations. for any of you that are practicing, I would caution with jumping to double the maximum dose, because this is more than double the approved dose for glyburide, because we also found that glyburide does cross the placenta with umbilical cord concentrations at the time of delivery, about 70% of the maternal concentrations. And our safety data is limited up to 10 milligrams twice daily. Again, as I cautioned with metoprolol, the beta blocker, I would also caution you in reminding you that the response to therapy is likely to be very different in pregnancy as well. These are glucose concentrations over a 24-hour period in non-pregnant and normal pregnant women. So each peak is in response to a meal. A couple things that you should note is fasting glucose concentrations are about 10 milligram per deciliter lower in pregnancy than in the non-pregnant state. Postprandial glucose concentrations are much higher in pregnancy, and then the concentrations come crashing down, and preprandial glucose concentrations are also substantially lower in pregnancy than the non-pregnant state. So when we're using these drugs, we need to keep in mind that as we look at alternate dosage regimens, that the women are very different in pregnancy than they are when they're not pregnant. This is the insulin concentrations going along with that, and you can see, of course, that insulin concentrations are far higher in pregnancy than in the non-pregnant state. It is a state of insulin resistance and hyperinsulinemia in order to compensate for the degree of insulin resistance in pregnancy. The last enzyme I'm going to talk about is UGT1A4. This is the data with Lamotrigine, looking at the ratio of Lamotrigine concentration versus overdose. So dose normalized concentrations, and this is the percent expressed of baseline. And you can see across gestation that the dose or the concentrations fall. The dose normalized concentrations fall and stay low and then return to baseline postpartum. But again, very big changes in phase 2 metabolism as well as phase 1. It's not just the elimination of drugs that's changed in pregnancy. The disposition of drugs during pregnancy is also altered. Body weight increases during pregnancy. Generally speaking, physicians recommend around a 25-pound weight gain during pregnancy. For those of us who have had children, we can tell you it's very easy to gain a whole lot more than that. This is the data from the Atenolol study and the body weights in the second and third trimester of pregnancy compared to postpartum. One thing I'd like to note is that for many women, they aren't back to baseline at 3 months postpartum, and some of the women just continue to gain weight even into the postpartum period. So they're not back to their baseline often even 3 months after their delivery. Another thing that can change the disposition of drugs is changes in protein binding or binding to other substances. These are the percent decrease in albumin concentrations early, mid, and late pregnancy. In addition to decreased albumin concentrations, we also know that there's a decrease in alpha-1 acid-glycoprotein with an average decrease of 52% in alpha-1 acid-glycoprotein in pregnancy. The third thing that I've talked to the students about for a long time but didn't really have an example of until recently is that the changing hemoglobin and hematocrit, the anemia associated with pregnancy, can affect the binding of some drugs. And I'll show you the data on tacrolimus as an example of that. Phenytoin, being a drug highly bound, is highly bound to albumin, It had been shown to have increased free fraction in pregnancy in the second and third trimesters of pregnancy, and particularly at the time of labor and delivery, as shown by Yerbe's data. This is our recently published data on tacrolimus. Tacrolimus is an immunosuppressive drug with a narrow therapeutic range, and near and dear to my heart, I actually started in transplantation as my first area of research. So what you're looking at in the first panel here are dose-normalized tacrolimus concentrations early, mid, and late pregnancy compared to 3 months or more postpartum. And in these women, you can see that the concentrations fell. And in response to that, looking at the panel on the upper right, the average tacrolimus dose during pregnancy was increased by the physicians to compensate for that. So the upper left panel is whole blood trough concentrations. That's what we monitor therapeutically. And the upper right being the dose that the physicians adjusted to maintain normal whole blood trough concentrations, as can be seen in the bottom left panel. They did a really good job adjusting the dose to keep the concentrations in the therapeutic range. And so they were all very content with this until we looked at what happened to the unbound concentration. Now, tacrolimus is a drug that is very lipophilic. It's concentrated within the red blood cell. It's also highly bound in the plasma to albumin. So although the physicians, since we monitor whole blood concentrations of tacrolimus, thought that they were maintaining concentrations in the therapeutic range, in fact, they were actually increasing the unbound concentration. And when we looked at the correlation between unbound concentration and serum creatinine in these women, and as well as creatinine clearance, there was a correlation, a fairly good correlation with unbound or plasma concentrations. And so the changes in hemoglobin and hematocrit, as well as the low albumin in this population, is really affecting the way we interpret drug concentrations in pregnancy, because clinically we're not measuring plasma concentrations. It's a little bit challenging because of the temperature-dependent distribution into the red cell, as well as concentration-dependent distribution into the red cell. And yeah, so it's quite problematic. Let alone measure unbound concentrations for medical centers to have an assay sensitive enough to do what we did on the research arena is quite a challenge. So I hope that gives you an overview of some of the changes that are occurring in pregnancy. All of these have significant clinical implications, and I hope that we can work on building our critical mass of investigators in this area to begin to solve these problems. I'd like to thank my funding sources, the FDA through the Office of Women's Health, as well as the Office of Counterterrorism and Pediatrics. You know, why counterterrorism and pediatrics got put together, who knows? And then, of course, NICHD, who've been very generous with our research program, and it's been very much appreciated. Thank you for your attention.